if you overstretch that muscle of the heart, then what will happen? An increased preload is not beneficial anymore because it will cause more problem than good to the patient. Right? Another possibility is, let's say for example, I have what do you call this? Hyperbulimia. If I have hyperbulimia, too much blood, then that can cause overstretching of the muscle of the heart as well, and that can lead to uh, loss of recoil and decreased contraction force of the muscle of the heart, leading to, again, increase in preload. So, an increase in preload is not good if you have a weak heart, such as in the case of congestive heart failure, right? So, if you have congestive heart failure, or you're taking care of a patient with congestive heart failure, we don't want that patient to be to have cardiac overload, right? We don't want that patient to have hyperbulimia, right? So, what does it mean? Patient with congestive heart failure should have or should restrict the sodium in their diet, right? And that's the reason why patient with congestive heart failure, a lot of times doctor will be prescribing low sodium diet, like 2 grams or 3 grams of sodium per day. Why? Because if they eat foods high in sodium, then they will be, you know that sodium reabsorb water or retain water. And if they retain water, they will have hyperbulimia, and they can have an increase in preload, which is not beneficial considering they have a weak heart, and that will just increase the preload, and the more that it will cause problem. Alright? So, low sodium diet, moderate exercise, because you need to strengthen the muscle of the heart as well to improve the stroke volume, thus improving the cardiac output. But again, preload, an increase in preload or too much preload will not be beneficial for patient with congestive heart failure or even with cardiomyopathy. Right? Now, flip side, what do we mean by afterload? The other term right here. Okay, here's the afterload. Alright, I have a caricature here. Look at this. Say preload is the volume coming to ventricles, and this is the amount of blood in the ventricles at the end of relaxation just before contraction, right? And diastole just before systole. What is afterload? Afterload refers to the resistance. Afterload refers to the resistance offered by peripheral blood vessels against the contraction of the left ventricle. So what does it mean? It refers to the peripheral resistance offered by peripheral blood vessels against the contraction of the left ventricle. So, an increased peripheral resistance will mean an increase in afterload. And what are the conditions that will increase peripheral resistance? If I have hypertension, what does it mean? Hypertension means the blood vessels are constricted, right? So if you have a very narrow blood vessels right here, if the blood vessels are so narrow due to hypertension, what will happen? Your left ventricle must exert greater force or effort to push the blood towards the aorta, to push the blood towards the general circulation. That should be okay if you have a strong left ventricle. But if you have chronic hypertension, you have narrowing of your blood vessel, then what will happen to your left ventricle? It will be pushing blood, ejecting blood towards the general circulation. And because you have constricted blood vessels, therefore, it must exert greater effort or greater force to push the blood towards the aorta. Now, that increase in the resistance will mean an increased workload for the heart, workload for the left ventricle, and an increased workload for the left ventricle will mean an increased oxygen consumption, and so therefore an increased oxygen demand. So, once in a while, during strength activities, maybe, yeah, you can have an increased workload for the heart. But if you have an increased workload for the left ventricle every single minute of the day, well, the left ventricle will also complain, hey boss, I mean, I've been working really, really hard, but you keep adding resistance and you keep adding, what do you call this, workload to me. Remember, the heart is also subject to the all or none law. Remember that law? All or none, meaning the muscle of the heart or the heart will function to its fullest, all, or it will simply stop. And you don't want your heart to stop, right? If that left ventricle is working too hard, pumping out the blood towards the general circulation, and you keep adding workload because you have vasoconstriction, and what will happen to the heart? That heart will get tired one day, and instead of working, the heart will just say, oh, I cannot take this anymore, I will just stop working. And once the heart stops working, then yeah, goodbye, bye-bye. Alright, but anyway, so you don't want that to happen. So what does it mean? An increase in preload is not beneficial because that can overstretch the muscle of the heart, and overstretching the muscle of the heart will mean losing the recoil, losing the force of contraction, causing very weak heart. And of course, an increase in afterload is not good either because an increase in afterload will mean an increased workload for the left ventricle. An increased workload will mean an increased oxygen consumption, oxygen demand, and you don't want your heart to be working too hard because of this resistance right here. Another case or another situation where you may have an increase in afterload is if you have, let's say for example, you have stenosis of the aortic valve. If this aortic valve is so narrow, so small, then what will happen to the left ventricle? This left ventricle again must push the blood towards the aorta against that very narrow valve. And so what will happen to the left ventricle? Again, increased workload, increased oxygen consumption, increased oxygen demand, right? Now, if this problem is coupled with atherosclerosis or coronary artery disease, wherein the supply of blood to the myocardium of the heart is markedly reduced, then what will happen? You're increasing the workload of the heart, and then you're decreasing the blood supply. That's a double whammy, a good recipe for myocardial infarction and cardiac arrest. Okay? Alright, so again, what is preload? Preload, by the way, Miss Parker and Miss Gower, remember, nicotine will cause vasoconstriction, and if you constrict the blood vessels, then it will cause an increased afterload. If you increase the afterload, you'll be susceptible for cardiovascular problems such as myocardial infarction. Alright, I'm just saying. Okay, going back to this, okay. Now remember, I was telling you earlier, the valve separating the right atrium from the right ventricle is called the tricuspid valve because it has 3 flaps. Now the valve separating the left atrium from that of the left ventricle is what we call the bicuspid because it has 2 flaps or 2 cusps. Now, The valve separating the ventricles from the pulmonary artery and the aorta, it's what we call semilunar valves, the pulmonic valve and the aortic valve. These are both semilunar valves. Now, when ventricles contract, remember, when ventricles contract, the semilunar valves will open, the AV valves will close. And the closure of the AV valves, preventing regurgitation of blood from the right ventricle to the right atrium, preventing regurgitation of blood from the left ventricle to the left atrium, right? So when the ventricles contract, PAM, open semilunar valves, close AV valves, producing the first heart sound known as S1. Again, you have two heart sounds, right? S1, S2, lub dub, lub dub, lub dub. S1, S2, lub dub, lub dub. When ventricles contract, semilunar valves will open, AV valves will close, producing the first heart sound S1, lub. When atria contracts, AV valves will open, closing semilunar valves, producing the second heart sound known as S2. Right? So this is lub, dub, lub, dub, lub, dub. S1, S2, S1, S2, S1, S2. Okay? So, some doctors, you probably heard some doctors saying, this patient has S3 sound, or an abnormal or an extra heart sound. So normally you only have S1, S2, lub dub, lub dub. If you hear another sound after S2, right? If you hear instead of lub dub, you hear lub dub e, lub dub e, lub dub e. That's an extra sound after S2. That's what we call S3, or sometimes called ventricular gallop. If you hear another abnormal sound before S1 or preceding S1, that's what we call S4 or atrial gallop. So again, normal sound is S1, S2, S1, S2, lub dub, lub dub, lub dub. If you hear an extra sound after S2, you hear lub dub e, lub dub e, lub dub e. That's S3, or sometimes called ventricular gallop. Ventricular gallop. G-A-L-L-O-P. Right? If you hear an extra sound preceding S1, like instead of lub dub, you hear dilub dub, dilub dub, dilub dub. That's what we call S4. So again, before S1, an abnormal sound before S1 is called S4 or atrial gallop. An abnormal sound after S2 is called S3 or sometimes called ventricular gallop. Okay? So, lub dub, lub dub, lub dub, lub dub, e, lub dub, e, lub dub, e, that's S3. Dilub dub, dilub dub, dilub dub, that's S4. Or, you say, Kentucky, 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 that's S3. Tennessee, 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 that's S4. Right? Sometimes you will hear sounds, abnormal sounds, in between S1 and S2. Sometimes you will hear loops, dub, loops, dub, loops, dub. Those are what we call murmurs, and those murmurs are produced by abnormal gushing of blood towards abnormal openings, such as incompetent valves. In case of incompetent mitral valves, produce abnormal backflow of blood to the left atrium. So again, S1 is produced by the closure of the AV valves, and S2 will be produced by the closure of the semilunar valves. Right? So when ventricles contract, these two AV valves will close, producing S1. When atria contracts, it will close the semilunar valves, producing S2 or the second heart sound. I know you're looking at the clock right now, right? No. Okay. blood vessels, and this will be the last part. After this, Miss Ireland will be giving you a little quiz. But like I said, let me reiterate, this cardiovascular discussion or lecture will not be part of your Monday's test. Your Monday test will only cover perioperative nursing, which is surgery. We discussed that Monday. And then respiratory, which we discussed Wednesday. Alright, so blood vessels, we have two major types of blood vessels, right? One type of blood vessel delivers blood away from the heart, so therefore most of them are delivering oxygenated blood. And we have another type of blood delivering blood towards the heart, and so most of them are carrying deoxygenated blood, right? So, those blood vessels carrying oxygenated blood and carrying blood away from the heart are what we call the arteries, and those blood vessels carrying blood towards the heart, thus carrying deoxygenated blood, are what we call the veins. There's only one artery in our body that carries deoxygenated blood, and that's the pulmonary artery. There's only one vein, actually two veins, carrying oxygenated blood, and they are called the pulmonary veins. The point where the veins and the arteries meet for the actual exchange of gases at the cellular level is what we call the capillaries, right? So, sorry, I made a little boo-boo here. Look at that. The artery is blue, and the venule and the veins is red. So, let's imagine this is the artery. This is the red, signifying, oxygenated blood. And the venules, the veins, is the blue blood vessels, because they're carrying carbon dioxide instead of the oxygen. So the point where the arteries meet, or the small arteries, the arterial, meets with the small veins, the venules, is what we call the capillaries. This is where the actual exchange of gases will happen at the cellular level. Oxygen will be taken in by the cells, and they will give up their carbon dioxide as a byproduct of their cellular metabolism. Right? If you will look at the layers of the blood vessels have three layers, right? The muscle, rather, of the blood vessels is three layers. The innermost layer is called the tunica intima, okay? The middle layer, which is also a smooth muscle, is called the tunica media. And the outermost layer, which is a connective tissue, is called tunica adventitia. So again, the tunica intima is the innermost layer. The middle layer, the smooth muscle layer, is called the tunica media. And the outermost layer, composed of connective tissue, is actually your tunica adventitia. Now, I remember I mentioned one time that if you remember your LDL and the HDL, the HDL is your high-density lipoprotein, and we say high-density lipoprotein means you have more protein than fats. That's why HDL is called the good cholesterol. While the LDL, the low-density lipoprotein, is called the bad cholesterol, because LDL contains more fats than protein. Okay? So if you have more fats than protein in one molecule, then it's called the low-density lipoprotein. Now, that low-density lipoprotein has high affinity to the tunica intima. I think I showed that to you one time. They love to stay at the tunica intima of the blood vessels, right? So if they love to stay at the tunica intima, here's another problem. This LDL, they want to have parties all the time. They will call their homies, they will call their their relatives and everybody, and they want to party at that tunica intima, right? But what will happen if you have a lot of low-density lipoprotein partying at one area in the tunica intima of the blood vessel. It will cause traffic, it will cause obstruction in the flow of blood, right? And if that obstruction happens to be in one of your cerebral artery, then what will happen? It can lead to a condition called TIA or little stroke, or you could have a full-blown cerebrovascular accident. If that atherosclerosis, which that's the technical term for that plaque formation in the coronary artery, okay, or in any part of the arteries, if that atherosclerosis happens to be in one of your coronary arteries, it will cause CAD or coronary artery disease, and it will markedly diminish the supply of blood to the distal portion of the arteries. That can lead to hypoxia of the cells. If that's the left anterior descending coronary artery, it will cause chest pain because the cells will be deprived of oxygen, therefore they will produce a lot of lactic acid, or you could have a full-blown myocardial infarction. Now, if that blood vessel happens to be in one of your lower extremities, it can cause deep vein thrombosis and obstruction or peripheral vascular diseases, right? So, you don't want your blood vessels to look like this. You know, you have plaque formation, and if you have plaque formation right here, it will cause severe narrowing of the blood vessels, and so therefore with severe narrowing of the blood vessels you will have obstructed highway, so the distribution or the delivery of blood to the distal portion of arteries will be markedly diminished. You want a good highway, no traffic, good blood vessels, smooth sailing, smooth flow of blood, smooth delivery of oxygen and vitamins and minerals to different parts of the body. Another problem with narrowed blood vessel like this would be it can cause a lot of blood clots, and you know what will happen if you have blood clots. Okay. I think I will stop here, and because after this we'll be talking about the different disorders. Again, I apologize for not being here personally, but I will see you Monday. Miss Gisla Ireland will be giving you a little quiz after this. I don't know if she will give you maybe 10 minutes break or 10 minutes time to review the notes. But the quiz will be all about the things that we discussed today. And I will see you Monday. Again, let me clarify, let me reiterate. This discussion, cardiovascular system, will not be included in your test Monday. Your test will only cover respiratory and perioperative nursing or client having surgery. Right? Thank you very much. Have a good day and have a good weekend. I'll see you Monday. Right? Thanks.